I've been running the bariatric program here since 2000. Wow, so it's been about 18 years since I've been at Lenox Hill, and we were the original place that gave the world the Skinner. Al Roker was on 60 Minutes when we actually did the first story about type 2 diabetes and things like that. So we've been doing this a long time, and the purpose of this seminar to a lot of extents is to actually kind of explain to you, what we've learned through the years, what some of the misconceptions are about obesity. And I like to do it before I know anything about anybody, so that everybody has a very, very strong opinion when it comes to obesity. So I like to try to give you at least what our editorial gestalt is from being involved in this for 25 plus years, and having had the privilege to operate around the world and speak about around the world, not just about bariatric surgery, but the whole obesity epidemic. I gave actually the keynote address at one of the gynecologic meetings about the impact of obesity on women's health. I've spoken throughout the Middle East and throughout the world about obesity. So I think the real objective of coming to, the reason people are sitting here right now is because they're trying to understand, and what they really want to try to understand is, why is bariatric surgery potentially different, and why is this different? What actually leads to obesity? What is obesity? And every time you begin to go on a diet, you actually think that it's going to be effective. You think that this is going to be actually the thing that really, really works. New Year's resolution, and you watch a show like The Biggest Loser, and it seems very, very easy. You're going to eat properly, you're going to exercise more, you're going to lose weight, you're going to change the habits, and lo and behold, what do you think happens? You lose a nominal amount of weight, then you kind of rebound, and you then come to a slightly higher weight, and that condition continues and continues. And the truth of the matter is that's really what summarizes the patients that we see in bariatric surgery. Yes, you can see people like Leonardo DiCaprio that gain weight to fill a part in a movie, but they're able to lose it. But when our patients try to do that, they never ever lose that weight, and they go back to a higher weight. And that's called the set point theory of obesity, and that begins to give us insight. And one of the things that I will tell you is that obesity is an energy storage disease. And in a nutshell, what we do with surgery is we actually change that set point. So what does set point actually mean? It means that there's a weight that your body feels comfortable, and each time you kind of change your eating pattern, when you're seriously obese, your body kind of wants to rebound. It wants to get back to that weight. And usually what happens with every single yo-yo diet is you actually go to a slightly higher level. Now, one of the reasons that we're beginning to understand, and for some reasons that we don't understand, bariatric surgery changes that level. Now, it doesn't make you immune to weight regain, but even when our patients regain weight, which is very fascinating, they very, very rarely ever go above their highest weight before we have surgery. They may have recidivism of a certain percentage, and that just goes to show that we're actually changing mechanisms in the body. So when you first hear about bariatric surgery, kind of what you're thinking is that we're making it more difficult to eat. You eat too much, you're going to throw up. Behavioral therapy. The truth is that there's a lot more about what we do in surgery that's been very, very hard to duplicate, and that's kind of some of the things that I want to talk about today. Well, the true definition of obesity means that you have excess adipose or fat tissue. Very difficult to measure fat tissue. You can go into pools. You can kind of use some of those scales they have in gyms that send electric shocks. Basically, the electric shock goes through the tissues that have water in your body. Fat is very, very resistant to water, so it estimates your fat percentage. The problem with that is if you have 3 of the glasses of water in the back, you'll change those numbers. So it's not really convenient to measure out percent body fat unless you play for one of the sports teams and you feel that here that like LeBron James has 4% body weight. So we use indirect numbers. So the first one we use is weight. Problem with weight is if I say 300 pounds, it sounds like a lot of weight. But what if I told you the person's 7 feet tall? And it's not as big. So we put height and weight together into a number called body mass index. That means if you have a lot of muscle, you'll also have a lot of body mass index, but that's usually not a problem for us in obesity. And essentially what we say is that a normal body mass index is 25. Class 1 obesity is a body mass index of 30. Class 2 obesity, which is really where we usually begin to treat people surgically, is a body mass index of 35. And class 3 obesity is a body mass index of 40. And that's really where we really begin bariatric surgery, except for people who have real big medical problems. And the reason why is because when you get more and more obese, what you'll find is that the medical problems that people have are like a J-shaped curve, meaning as you go up the curve, the J gets a little sharper. So as we go up and get more and more overweight, the impact on people's health becomes greater. So it really, really justifies an aggressive treatment like surgery to get people to lose weight. And I think that that's really some of the stuff that we're going to concentrate when we go on. What's really amazing is that when Bill Clinton was president, which doesn't seem all that long ago, I guess we're aging quickly, it seems the obesity rate in the country was about 15%. Fast forward to today, where most estimates say of adult females, the obesity rate has gone up to 40%. When we look at certain ethnic classes, it's even higher. The overall obesity rate of most adults is about 35 to 36%. So that means in about 25 years, we've seen these things double. And the question is why? You know, sometimes people say our society is less active. Possibly true, there's more sedentary jobs and less labor. But as far as I'm concerned, several things happened when I was a child that probably explain some of the obesity epidemic. One of the things that I think is people don't talk about, and when I first mentioned this to Elizabeth Cohen of CNN, she was wow, is the inadvertent consequence of cigarette smoking. Please don't go out and smoke because it's probably the worst thing that you could possibly do to yourself. But it basically talks, explains habits. And it used to be possibly when you're stressed, when you were bored, you might have lifted a cigarette. Now you're lifting food. And you're not just lifting any type of food. You're lifting the foods that are convenient to eat. And what are the foods that are convenient to eat? They're processed, they're full of carbohydrates, they're full of salts, they're full of a lot of things that come in a package that usually aren't the best for you. The other thing that really happened is kind of our perception of what healthy food was really, really changed. And maybe not so much for the better. When Eisenhower was president, he had a heart attack in office. Okay, he had a heart attack in office. And that made people very, very concerned that young men were having really fatal heart attacks and MIs. And what they also didn't account for was cigarette smoking. So the United States government decided to look at countries that were having a lot of heart disease. And what they found was that countries like Finland, where they ate a lot of meat and cheese, were having more heart attacks. But again, they didn't adjust for cigarette smoking. So they decided that if you basically took cholesterol out of the diet, you would never have heart disease. So I don't know if you remember, we took away butter from the table, and we had margarine. We didn't just have any margarine, we had Fleischmann's margarine, which is like cancer in a tube. We told people stay completely away from cholesterol. Well, the problem is, and we still want people to eat low cholesterol diets, is that cholesterol mainly comes from animal products, mainly comes from with foods that are fat. So when we told people to take cholesterol out of the diet, what did they inadvertently replace it with? Carbohydrates. And not just any carbohydrate. Carbohydrates are divided into two classes, simple and complex. Our dietitians and Sharon will really educate you about that. But there is no such thing as a simple carbohydrate in nature. Humans are the only species on the planet that eat simple carbohydrates. And that means you take the germ away from the wheat, you take the juice out of the orange, okay, and you basically turn it into pure sugar. Okay? And what's happened is that we have replaced a lot of our diet has become simple carbohydrates and processed food. And with that, we've seen the obesity epidemic. And especially when you add to the stuff that the Midwest, which used to grow a whole bunch of different crops, now basically grows corn and soy because of the subsidies that were given to farmers. And that's where your fructose corn syrups all come from. So we've really had a subtle change in our diet that really hasn't been to the best. Well, when I give a lot of talks, I usually start out by saying the accounting theory of obesity, calories in, calories out, that we've all been brought up, that makes it very good to sell Weight Watchers products, only leads to fat accountants. Okay? So the first thing I want to tell you is that the idea that you think about obesity is kind of being like your bank account, and you're going to have deposits, which are your food, and you're going to have debits, which are your withdrawals. And if you go to the exercise class and you see the machine is 1,000, and then you go downstairs and you only have a 300-calorie donut, you're going to be 700 calories ahead. Notice that that 3,500 calories equal a pound. Notice how the math has never worked for any of the people in this room. And the truth is that obesity is an energy storage disease, going back to what I talked about in set points. And that people who are afflicted with severe obesity will defend their set point. That doesn't mean that every person in the world will defend their set point, but people who are morbidly obese are much more likely to defend their set point, be resistant to weight loss, and when they lose weight, more likely to yo-yo back. And what causes a lot of this is probably inflammatory response, and probably the key to everything, the key hormone, or one of the key hormones, is actually insulin. So obesity is really a hormonal disease, and essentially when you eat certain foods, all calories aren't created equally, and I'll talk about that, you're going to see a rapid rise in insulin. Now we all know about insulin being important in diabetics, but the truth of the matter is insulin is the hormone that tells your body to store fat and prevent fat from breaking down. Insulin is probably very, very important, and insulin binding globulins in supporting tumor growth. Sugar is a great place. Sugar and insulin make a great recipe for cancer cells to potentially grow. So if you think about foods, what your really goal is to try to keep your glucose down and your insulin levels down, because the foods that elicit, or the glycemic index foods, are going to elicit the highest insulin response, and they're going to drive the most food into your cells and be most likely associated with weight gain. And it's funny, exercise actually makes you much more insulin sensitive. And every single thing that we know about that expands life, even metformin, bariatric surgery, actually lowers your fasting glucose and the amount of insulin that you require to keep your glucose normal. Women with PCOS, polycystic ovary syndrome, biggest source of infertility currently, they have what's called insulin resistance. And what frequently happens is, so they don't become diabetic, they make more insulin to control their sugar. Body doesn't want to be diabetic. When you're diabetic, you spill glucose into your urine, you urinate frequently, you become dehydrated. So in order to maintain their sugar, they have to secrete more insulin. When they do that, that's blocking their ability to break down fat and creating a whole cascade that favors weight gain. So again, I don't believe that obesity is accounting. I think that all calories, and I hate to sound non-democratic here, but all calories are not created equally. If you have a rapidly absorbed fruit juice that has a lot of sugar, that's going to behave differently than if you have something bulky that has a lot of substance to it. The second thing I think is really true is that the way people handle calories, all people's ability to handle different foods is not created equally. So just because you eat something and your friend can eat 2 pizzas at night and not gain weight. I had a friend who played basketball when I went to college. He had a pizza every single night, weighed 170 pounds. We would do that. We'd look like blah, blah, blah. People's ability to handle calories is not the same. And again, it goes against the whole accounting theory. And what's really, really interesting is even when you eat things, your body may handle them differently depending on the order that you ate them in. There may be something to having a sweet after you have your meal rather than having something sweet before your meal. Because, mixed in with a lot of food, it probably is not going to elicit the same insulin response if you have dessert than if you just had, you know, a glass of fruit juice, which is going to be absorbed very, very quickly. So they're very, very different things. The problem is that over the course of time, we're not, you know, we're getting taller, but we're also getting heavier with more fat tissue. And that has a lot of problems. So the idea that you're going to be the healthiest heavy person, there's no question about certain facts. Number one, not every person with severe obesity is going to die young. But the people that have severe central obesity and metabolic syndrome have a very high risk of cardiovascular disease. There's no question that people whose obesity is in the subcutaneous tissues, in the hips and the buttocks, they're much less likely to have heart disease, diabetes, and hypertension. But I see a lot of those patients, and the reason they come in is because the tires are going. The engine is fine, but the stress on their legs. So if you're really heavy and you have a bottom distribution, your mortality probably isn't adversely affected, but the problem is you're 10 times more likely to require a knee replacement. And the knee replacements and the osteoarthritis treatments don't really work great for people that have very large obesity. So when you go head to toe, there's not a system in the body that obesity doesn't affect in certain people. Sometimes we see people who can go blind because of headaches from idiopathic hypertension from obesity. Pulmonary disease, sleep apnea, virtually every single patient that I see has some degree of sleep apnea. And the implications of that are enormous. Sleep apnea is a condition where you actually block your airway at night when you go to sleep. And your spouse will tell you you're snoring real loud. The body's an amazing machine, and it wakes up so that you can breathe when your oxygen goes down. The problem is you don't recharge your battery, so that it's been shown that people who are very heavy have difficulty concentrating. Oftentimes they don't perform as well as work. Actually, their risk, UPS has recently done a study that showed that people who are morbidly obese are 5 times more likely to be involved in a car accident. And that all probably comes from sleep apnea. I don't know if people remember there was a train that crashed right after New Year's coming from Westchester, and that was because the engineer had sleep apnea. And that's amazing. I just was part of the American College of Occupational Environmental Medicine, and the impact of obesity on the workforce is getting very, very large. A condition people don't hear about a lot is called NASH, or non-alcoholic liver disease, fatty liver disease. And essentially, believe it or not, obesity is replacing alcoholism as the leading cause of liver failure in this country, and it behaves exactly the same way. And a lot of people believe it's the fructose in sugar that basically damages the liver. Notice before you had the obesity epidemic, you could watch a football game without seeing a commercial for low testosterone. Obesity affects all of your sex hormones. It's one of the leading causes of infertility for both males and females. And what's even surprising is that the American Cancer Society believes that obesity is going to surpass cigarette smoking as the leading cause of cancer deaths in the United States in the near future. You'll say, well, how does obesity affect cancer? Well, several ways. Obesity changes all of your sex hormones, so certainly tumors like postmenopausal breast cancer are really significantly impacted by obesity. The other thing is that the same conditions that encourage obesity, high insulin binding globulins, elevated blood glucose, are a very nice medium for tumors and tumor cells and things like that in cancers to grow. So people who are seriously obese who, God forbid, get cancer also have a higher recurrence rate, and it's much, much harder to treat. What's really good about surgery, using diabetes as an example, is that your medical doctors do a great, great job of treating your medical conditions, your hypertension, your diabetes, and giving you medications so that you prevent any of the side effects or the complications of obesity. But the truth is, most people here, once they're on a medication, they're usually on that medication for a long time, or they change the medication, or they add a medication, or they increase the dose. So what we really offer in surgery is the opportunity for regression and remission of many medical problems. And usually what you see as an adult when you start seeing your internist about hypertension, hyperlipidemia in diabetes is usually at best control and stabilization, very rarely reversal. And when we actually look at different operations with bariatric surgery, with our most aggressive operations, we can actually get approximately 90% of the patients off medications. Not 100%, depending on how aggressive our procedure is, but we can really get remission of medical problems. Notice what word I didn't use. I didn't use the word cure. And the reason why I'll never use the word cure is because your genetic makeup doesn't change, the environment doesn't change, and what broke the system to begin with was the combination of eating in this environment. So we reverse it, but if you subtly go back to eating exactly the same foods, what do you think will happen? We'll have recurrence. Yeah. You'll have recurrence. And surgery will ablate that response to some effect, but not all. And that's going to be another theme that we're going to talk about. So there's a lot of reasons that surgery works. It's not just that we're making the package smaller, the stomach smaller. This is a very, very complicated slide explaining all of the mechanisms why surgery can reverse diabetes. And notice you see the brain, you see the liver, you see the pancreas, you see the stomach, you see the intestine, you see the muscle. And the bottom line is that's so fascinating, is that by changing the GI tract, we change all of these different mechanisms. So one of the things that people ask is, Dr. Roslin, is there going to be a magic pill for obesity? And the answer is there may be. But one of the problems that everyone has in duplicating what we do in the operating room is it would probably take 15 to 17 pills to do all of the subtle things that we may do in a gastric bypass, a sleeve gastrectomy, or a duodenal switch. So there's a lot more. So one of the simple ways to explain that is that surgery, yes, it works for mechanical reasons because we're making the stomach smaller, but it also works for hormonal reasons because we're changing the messengers that go from the gut to the brain, and we're changing the neural impulses that also go from the gut and the brain and back and forth. So there are a lot of reasons why surgery works that go beyond what we initially imagined years ago when people said that these things, we started studying these operations. So what are our options for obesity? Pretty much we can manipulate either the stomach or the first portion of the intestine or both. Now, one of the things that's logical about obesity surgery is the more we change the body, the greater the weight loss. The greater the weight loss, the greater the risk of micronutrient deficiencies. So obesity surgery is a balance between those things, and that's why we spend time discussing this. One of the things that I will talk about as we go forward is the stomach, when we manipulate, certainly gets weight off. The intestine helps keep it off. But the role of the intestine is to absorb our nutrients. As a result, when we manipulate the intestine, it is really important that you take your supplements for the rest of your life and eat the correct foods so we don't replace vitamin and micronutrient deficiencies with obesity. Obesity surgery is a controlled abnormality. It really works very well for giving people a fresh start, a more active lifestyle, but we really have to be aware of its limitations so we minimize the chance of replacing one problem with another. So you've probably heard about, if you listen to the radio, you've heard about the Obalon balloons or balloons. I actually think that balloons for people who have morbid obesity are a very bad idea, to be perfectly blunt. And the reason is because of what I talked about in set points and yo-yo diets, and the idea that surgery changes a lot of different mechanisms. So maybe for people who don't have an energy storage disease and want to lose weight quickly, it may be appropriate, or smaller patients. But anybody in this room have lived through the liquid diet phase? Okay? The people who are my age and above remember Metafast, they remember the Cambridge diet. The young people really don't because it's become a little less popular. But people that lost tons of weight, okay? Nobody in the world knows anybody that maintained weight loss after a liquid diet. True or false? Okay? It's a sum total of 0. And what do you think will happen if you put a balloon in somebody for 4 to 6 months and you take away the balloon? You're going to see that same yo-yo that I started with the set point. because you're not changing any of those mechanisms of action. And you wait long enough, if the person has an energy storage disease, they're going to reach a higher weight. Another thing that people are talking about is trying to mimic what we do to some extent with the sleeve gastrectomy by going through your mouth and suturing. Again, I can tell you, having done this for 25 years, we actually remove part of the stomach and make a very straight tube, and we see a fair amount of recidivism. My concerns with these operations is you're never going to have symmetry, so you're going to develop pressure gradients above and below where these sutures are, which is essentially going to stretch them out. And by a year, you're only going to be about $8,000 poorer. And I don't think they're really going to last at all. And I think that, again, one of the things that you will find in obesity is that everything works at the beginning. You want to know why? Listen to how quiet it is in this room. Everybody's listening. Everybody is here because they want things to work. So for the first 3 months, everything works. So when you really look at operations, what you want to see is consistency in results. That people will lose approximately this much weight, and virtually all patients lose that weight. And if they can't give you that statistic, then it means it's very people dependent, if the results are very variable. And what you'll look at our results is our results are very predictable depending on the operation up to the first year. After the first year, they become very divergent. And you know what that means? Is that the operations are very powerful to getting you to lose weight, but your behavior and the structure that you incorporate and the new habits you develop are going to determine your long-term outcomes. So the first year, it's our job to kind of break that set point, to give you a new thermostat, but it's your job to understand the limitations and to use that tool effectively long term and not get into a false sense of security. So it's kind of interesting, and I'm actually very proud, because I probably had a lot to somewhat do about this, is that the procedures that we're doing have changed markedly in the last 7 years. And it's interesting, we did our first sleeve gastrectomy here in 2004, right after Mount Sinai, and by 2007, we had pretty much been doing sleeves and doing less bypasses, and we kind of paved the way with bypass with people, as I mentioned, like Al Roker. And lap bands have virtually gone the way of the BlackBerry. They've gone from about 40% of the bariatric procedures to now less than 6%, and that's because more bands were coming out than going in at the present time. An interesting bypass, which was the most prevalent stapling procedure, has now gone down, and sleeve gastrectomy's gone up. And to talk about some of those things. So gastric bypass was actually, is a very effective operation. Let me just.
The surgeon examines the abdomen.
A very effective operation for obesity, but I actually think for primary obesity, there are probably better choices. And I use this operation for patients that have had complications from other procedures or have very, very severe reflux. And a lot of my research has been on some of the limitations of bypass. What happens with a gastric bypass is you cut out a small pouch of stomach, like you see there, and then food bypasses the stomach, and it meets down low in the intestine, creating the so-called Roux-en-Y. Theory A, small stomach, forced to eat less. Theory B, by bypassing the stomach, food goes into the intestine, rapidly stimulating the intestine. And one of the things that was taught, when I started doing bariatric surgery, is that if you ate sweets, you were going to get what's called dumping syndrome. And that doesn't mean you're going to run to the bathroom and take a dump. It means you're going to get lightheaded, heart racing from eating certain foods and simple carbohydrates. And it was taught that gastric bypass would reduce sweet ingestion because you were going to get this negative symptoms, almost like you were going to get sick when you drank alcohol, so you'd no longer drink alcohol. The truth of the matter is, and I've been really very, one of my areas that I've actually spoken about around the world, what happens with a gastric bypass is you actually get a rapid insulin response, and you get a rapid rise in glucose and a rapid low in glucose. And what happens to many people years later is when your glucose is low, what do? Eat. So it basically has what I call a lot of glucose variability. meaning the glucose goes up and down. And I think that there are better things to do, and I think that's going to become a coming trend. I still think it's an effective operation for people, especially if they have reflux, but in order to reduce that type of chance of having that type of glucose variability, what I've tried to do with my patients, as well as Dr. Yatko, is we've tried to preserve the valve at the end of the stomach called the pylorus, which actually means gatekeeper, and it kind of slows gastric transportation a little bit. And we don't see, you can still see some low sugar, but we see less of this glucose variability. And as a result, when we started discussing that, we were very quick to go to procedures like the sleeve gastrectomy. And this is what a sleeve looks like. When we do a sleeve gastrectomy, we're not putting in a sleeve. What we're doing is we're taking this big spherical organ called the stomach, which looks like a sphere and, and can hold a lot of food, and we're turning it into a narrow tube. My Orthodox Jews say it looks like a shofar, other people say it looks like a banana, and we're turning it into a narrow tube by removing part of that stomach. Interestingly, while it looks like we're just making the stomach small, we're doing a lot of different things as well. When you eat something, the first thing that the stomach does is it relaxes to receive the food. That's why you don't get full in Thanksgiving. It's called receptive relaxation, and you put mucus. When we remove the part of the stomach that stretches, it almost feels like a rock is hitting you go down, and patients get full very quick. And that's why I tell them early to just drink hot liquids, because if you drink fast, it's going to feel something. Yeah. The other thing is the part of the stomach that we remove is more than just a storage organ. It actually sends hunger signals to the brain, best studied called ghrelin, and begins to explain why our patients not only get full faster and eat less, but they're also less hungry. It's not uncommon after bariatric procedures, gastric bypass or the stapling procedures, sleeve or modified duodenal switch, that our patients sometimes have to remember to eat. Unfortunately for most, that doesn't last a lifetime. It's definitely, it definitely happens there. And what I find with sleeve is, by and large, when sleeve's well done, you get a weight loss that approaches the gastric bypass without having to use the intestine. So the good part of a sleeve gastrectomy is that you don't use the intestine, so the likelihood of vitamin deficiencies is somewhat lower than bypass or the duodenal switches that I'm going to talk about, because you don't use the intestine. The bad part is you don't use the intestine, so that means if you eat something, you're likely to absorb it and have somewhat a weight regain. The intestine, especially when you go long, does mitigate against weight regain to a certain amount. And when we want people to lose more weight, what we do is an operation that I've been really involved in developing, which is a modification of the duodenal switch. And I did a lot of the classic duodenal switches. I've done tons of bypasses, and I think for patients that need to lose a lot of weight in BMI of 50, I see that this is really going to be the future. And essentially what this is a sleeve gastrectomy where we make the stomach slightly bigger, and you have approximately 22 feet of intestine. We splice the food so it only uses the bottom 10 feet of intestine. Does that make sense? So basically we jump the food from the stomach to the mid portion of the intestine, so you're only using half of the intestine. And when we do that at 3 meters, we're getting patients that are mostly moving their bowels about 2 times a day and getting about 30% more weight loss than the sleeve gastrectomy with lower weight regain. Does everybody need this aggressive? No. But again, if your body mass index is more than 50, you probably make sense to consider things. And we're going to talk a little bit about that. So when, I think that when we go to the internet, what people see about the results about bariatric surgeries, you see words like 60 to 70% or 80% of excess weight. And the answer is, are those things really true? And the answer is, they are true if your body mass index is about 40 to 42. They're not as true if your body mass index is 50. I'm lucky that I've always had excellent research residents. So I had our research resident look at every single sleeve that was done here a few years ago and get results from every single person so that we could really categorize the one-year results, which is really where you see the nadir results of sleeve gastrectomy. And what we found is if your body mass index is less than 40 and your goal is to no longer be obese, you had about a 95% chance. If your body mass index was 40 to 45 and your goal was to have a BMI of less than 30, you had about a 60+% chance. When it got to 45 to 50, that went down to 30%. And if your body mass index was more than 50, okay, if body mass index was more than 50, you had less than a 5% chance of having a BMI of less than 30 at 1 year. So pretty much what happens is if your BMI is about 42, you'll lose about 70% of the amount you're overweight. When your BMI gets above 50, you're down to losing about 50% of the amount you're overweight. And what we basically saw is people lose about 31% of their total body weight. So think about it, if you're 300 pounds, the average person was losing about 90 pounds. So now, interestingly, when I go ahead and I do the DS, we see that that number goes down up to about 50% of the people who have a body mass index of 50. So it goes to show that, one, what we're seeing is patients that are, you know, in the average day I may see patients that have BMIs of 35 to 70, and their results are going to be somewhat different. Yet when you look on the internet, that information is not there. The next question that people ask me, and they go, "Doctor, can I do better than that if I do X, Y, Z? You know, I'm going to exercise every day, I'm going to run this and that." And so the answer is I looked at how many patients are outliers, both high and low. Because if you have outliers that are high, you have to have outliers that are low. So we looked at, you know, with sleeve gastrectomy, what percentage of patients had lost more than 35% of body weight, and what percentage of patients lost less than 25%. And about 23% lost more than 35%, and about 14% lost less than 25%. And that tells you that it's a very effective treatment because, again, you see all of the people converging. And that tells you it's a treatment effect rather than the New York lottery or luck. But when you add the intestine, you get about 30% more weight loss. So trying to summarize all of this stuff is bariatric surgery is a great modality for people who have medical problems and really have functional impairment from their obesity. When you get morbidly obese, not everybody is dying. Some people have serious medical conditions, and you know who they are. But what we offer in bariatric surgery is the chance of remission, reversal, to some degree, a new beginning. Okay? But that comes at the cost of an operation, which is a controlled abnormality. So that means that certain things are going to increase. So for example, any stapling procedure can have a leak or a bleed. But we've gotten really good, especially in primary cases. When you really look at our complications, it's when we're doing the revisions and the really heroic stuff that people come all over the country here for. We've gotten good at the primary cases, and they become as safe as joint replacement or even cholecystectomy. Each of the operations can cause things. Bypass can have marginal ulcers, you know, and that's what I'm really intrigued about with the new modified DSs. I haven't seen them. They can have strictures, they can have small bowel obstructions. The sleeve gastrectomy, some patients sometimes complain of GERD. So we'd have to take care of that if it's really bad and convert it to something like a bypass. And obesity, you know, one of the things somebody asked me is, I only want one operation. Obesity is a chronic disease. So sometimes if we do a sleeve and the weight loss is not adequate, we'd have to do more. You know, it's a chronic disease. The DS patients are going to have a higher chance of having high bowel movements, although it seems to be controlled, and a higher chance of micronutrient deficiency, so we're going to have to get more blood work. So there is no perfect operation, and a lot of it is finding something that meets your objective. Again, we go through a very detailed informed consent, and bariatric surgery can have complications, but in centers of excellence, we have really gotten this to really reasonable safety metrics. And certainly when you're on multiple medications and you have, you know, diabetes and it's impacting the quality of your life and your emotional health, you know, the risks have really come down and the transition worthwhile. But again, you really do need to realize that you need to eat differently. Another question that people ask me is, what determines success? And it's really interesting. We see people of different backgrounds, different sizes. They come from different cultures. And I have never yet been able to figure out one recipe that makes people successful. But what I can tell you that all successful people have is a routine. They're very, very structured. They develop new habits. They eat the same thing at the same time. They work activity into their lifestyle. They're consistent in their sleep patterns. They basically lead a healthy lifestyle. One of the most frustrating interviews I ever did was with the Daily News, and the woman kept on asking me, what is healthy to eat after bariatric surgery? And I said, you know, it's exactly the same things that are healthy to eat before bariatric surgery. We're operating on your digestive tract. We're not making the Twinkie or Hostess cakes different. We're not genetically manipulating those things. And there is no substitute for eating a healthy lifestyle. We started with talking about the set point, right? But what broke the set point? What broke the set point was the environment that we're in, the foods that we're eating. So we have a chance with surgery to somewhat reset it. But if we went back to the same foods, what do you think would happen? We'd break it again. So again, sometimes people hear that and they say, well, why do I need an operation if I have to change my behavior? And I agree, if you don't want to change your behavior, that's fine. But if you really want to be successful long term, you have to understand that this is a fresh start and a new beginning, and you really have to learn about what to eat. And what really can fool people is several things. Number one, I can't tell you how many times people have told me, well, Dr. Roslin, I ate that because it's really easy to go down, so I thought that's what I should be eating. Pretzels will always be. There's no easier food to eat than cheese doodles, okay? You can be completely obstructed and your mouth will absorb a cheese doodle, okay? That doesn't mean that's what we want you to eat. It almost is inverse, and sometimes it's very, very difficult to eat leafy vegetables. So these operations don't have any brain power. They're not deciding what you eat. You're deciding what you eat. And it's really, really important that you understand its limitations. And as you move away from surgery, the skills that you develop and the new habits that you get are going to be the most important things. With that, I'll be more than glad to answer any of your questions, and we look forward to seeing you.